Good morning. I'll be presenting on behalf of Medicine 4. Presenting Mrs. A, 33-year-old lady from West Bengal. She presented with complaints of a gradually increasing upper abdominal swelling for the last 6 years. She did not have any history of fever, no weight loss or loss of appetite. There was no history of night sweats, no recurrent infections, and she did not have any history of jaundice. Her past history was significant for malarial infection in her childhood. And a treatment history over the last 1 year, she has been diagnosed with anemia outside and has been on oral iron supplementation for the last 1 year. There was no history of any complementary or alternative medicine use. On examination, her vitals were stable. She had a severe pallor, and her abdominal examination showed a massive splenomegaly extending 3 centimeters past the midline. The liver span was normal, liver surface was smooth, and there was no ascites. Summarizing, a 33-year-old lady from a malaria endemic region with history of malarial infection in childhood, presented with massive splenomegaly and chronic anemia with no fever or any constitutional symptoms. So considering this history and examination findings, the differentials we considered, the most likely differential we considered was a hyperreactive malarial splenomegaly syndrome. The other differentials we considered were either congestive causes due to non-cirrhotic portal fibrosis or a splenic or portal vein thrombosis, other infectious causes like visceral leishmaniasis or schistosomiasis, and infiltrative or malignant causes like CML or myelofibrosis, which can also cause a massive splenomegaly. So the baseline investigation, she had a pancytopenia with a low hemoglobin, a low total count, and a platelet count of 30 to 45,000 on smear. Her peripheral smear showed features of hypersplenism. There were no blasts on smear. She had an iron deficiency with a normal B12 and folate levels. Her liver function and renal function were within normal limits, and her malarial and leishmanial parasite tests were negative. Autoimmune tests for ANA and DCT were also negative. We had gone ahead with a bone marrow biopsy for this patient, which showed a normal hypercellular marrow with normal trilineage hematopoiesis and no abnormal cells on the bone marrow. So at the end of these investigations, we had excluded most likely infective causes, and given her lack of constitutional symptoms, malignancy was less likely in this patient. So we had also gone ahead with an imaging. Her CT thorax and abdomen had showed an irregular coarse ectotexture of the liver with a dilated portal vein, which was suggestive of CLD, but she also had a massive splenomegaly, which was out of proportion to the degree of the CLD. There was no evidence of any Budd-Chiari syndrome or portal vein thrombosis, and she did not have any lymphadenopathy. So at the end of these investigations, the two differentials we were mainly considering was a hyperreactive malarial splenomegaly syndrome or a non-cirrhotic portal fibrosis. Just briefly about hyperreactive malarial splenomegaly syndrome, it's a massive enlargement of the spleen due to an exaggerated immune response to malarial antigens. There is an either due to repeated malarial infections or due to an exaggerated immune response, there's a hyperproduction of IgM, which can cause the massive splenomegaly. The diagnostic criteria for this the major criteria includes splenomegaly, elevated IgM levels, and a positive malarial antibody test. Our patient, although she had massive splenomegaly, we had sent IgM levels which were negative for this patient. So that had ruled out a malarial splenomegaly syndrome. So the other differential was a non-cirrhotic portal fibrosis. So we went ahead with a gastroscopy, which showed large esophageal varices. So our diagnosis at this point was a non-cirrhotic portal fibrosis. So just briefly about NCPH. Non-cirrhotic portal fibrosis or non-cirrhotic portal hypertension, it's characterized by the presence of portal hypertension in the absence of cirrhosis on liver histology. It also requires the exclusion of extrahepatic portal vein obstruction and any conditions that may cause cirrhosis. The diagnostic criteria includes clinical signs of portal hypertension, which includes any one of the following signs, which is splenomegaly, esophageal or gastric varices, ascites, and portovenous collaterals, and also requires the exclusion of cirrhosis on liver biopsy. NCPH can be either due to idiopathic causes or it may be due to secondary causes. The criteria for an idiopathic NCPH includes the exclusion of secondary causes that may cause an NCPF. These are commonly hepatitis B or C virus, non-alcoholic steatohepatitis, alcohol-associated autoimmune, hemochromatosis, Wilson's disease, or primary cholangitis. So the pathophysiology of NCPH, there is sclerosis of the small intrahepatic portal venous branches. So there is preferential sclerosis of a few intrahepatic portal venous branches. So while a few portal venous branches are spared, so there is hyperplasia of the hepatocytes around the normal portal venous branches. So this is called nodular regenerative hyperplasia. So this hyperplasia of the hepatocytes can mimic the appearance of a cirrhotic liver on ultrasound, which was the case in our patient. Yeah. So this can mimic the appearance of a cirrhotic liver. So in our patients, we had in order to exclude the other cause of cirrhosis, we had gone ahead with a transjugular liver biopsy, which had shown features of portal and periportal vein sclerosis, and there was no evidence of cirrhosis on the biopsy, whereas the CT had shown features of cirrhosis. We had also ruled out other secondary cause of NCPH. Hepatitis B and C were negative. Autoimmune hepatitis panel was negative, and ceruloplasmin and schistosoma PCR were negative. Along with the transjugular liver biopsy, we'd also asked for a hepatic venous pressure gradient, which was 12, and a hepatic venous pressure of more than 10 is diagnostic of portal hypertension. So at the end of this, our diagnosis was an idiopathic portal venous hypertension. So the management for this patient, we had started on non-selective beta blockers for the management of esophageal varices. Transjugular intrahepatic shunt can be indicated in patients who are CTP stage B with bleeding varices, or if they're CTP stage C, or if the hepatic pressure gradient is more than 20. Our patient did not fulfill any of these indications. Splenectomy or splenic artery embolization can be done if the patient has a recurrent transfusion-dependent anemia, which is not the case in our patient. So the take-home points I want to say is that NCPH is to be considered in patients with massive splenomegaly and esophageal varices. In these patients, the liver can show a nodular reactive hyperplasia, which can mimic the appearance of a cirrhotic liver. To make the diagnosis of idiopathic NCPH, secondary causes like hepatitis B, C, autoimmune hepatitis, and schistosomiasis need to be excluded. And liver biopsy is not indicated in all cases of NCPH. If all the common secondary causes are ruled out, you can make the diagnosis of idiopathic NCPH without a liver biopsy. Thank you.
Thanks, Andrew. Questions? We'll move on to the last presentation of the day. From Medicine 5, Dr. Lino will be presenting on cocktail.